but I will speak about this project that was undertaken at the Burnett Institute primarily by a group of people working there and also in close collaboration with the Department of Home Affairs. And I believe I have 15 minutes, so I'll try to keep to that time. Okay. So this basically culminated in a report that we submitted to the Department of Home Affairs in 2018. The project was initiated by a public health trainee who is now a public health physician by the name of Yihao Cheng, or Hao, who initiated the project in 2016. He is a GP and he was then a public health trainee under my supervision. And he was really keen on looking at things like the links between, post-migration screening in general and migrant health, refugee health, those sorts of things. So he independently contacted the Department of Home Affairs, which I sort of told him was not likely to be a very fruitful exercise, and I was totally wrong about that. And he initiated this study back then. And so there was enthusiasm from the Department of Home Affairs to outsource some aspects of their migrant screening program. Outsource evaluation of the migrant screening program because they didn't necessarily have the capacity to do that in-house, and it was not focused on TB. It looked at a number of infectious diseases, and it was an interesting project, and it was a long, hard road, which I sort of expected it to be, although I didn't quite anticipate how that would pan out. But I think it's now produced some interesting outputs, which I'm very keen and happy to talk about. So certainly acknowledging the large group of people from the Burnett who were involved with this. And I guess we structured the team that there was one disease lead for each infectious disease of interest. And I was the lead for active TB. Of course, I moved on from the Burnett not long after this project was started, but I retained an adjunct position and kept working with the Burnett through that mechanism. And so I was the lead for active TB. There's also sort of a major component of the project is to look at latent TB infection, which I'm not the lead for, and we've just drafted the paper on, and that's been led by Ingrid Lamel-Ruff. And so hopefully we will move towards publishing some results from that as well. But I'm currently in a good position to talk about the active TB component because we've just published the paper that's come out of that. But just to talk about the general report a little bit in terms of the recommendations. I mean, I think one of our major findings was that the data that we received from the Department of Home Affairs was generally of a very high standard and has the potential to facilitate much linkage to programs that could improve migrant health in a range of areas, not just limited to TB. The data that we received was sort of multiple spreadsheets that pertain to specific aspects of the screening program, and there were things like departure health checks in addition to the main process, which is the immigration medical assessment. And so the data was a little bit split, but it was all linked together. It was all linkable together by a unique identifier that allowed us to collate it together to create one data set that was pretty comprehensive and allowed us to look at all of these different infectious diseases together. So I guess one limitation of it was that as much as it was a high quality and the format was quite good, like there weren't a lot of free text fields, you could analyze it reasonably well. There wasn't a very clear data dictionary associated with it. They did have a data dictionary, but there still was quite limited in terms of us understanding exactly what the terms meant, which was particularly important in the case of chest X-ray, for which we never really fully gained clarity on what was meant by each of the possible responses you could enter into the chest X-ray field. So in the case of TB, we made a number of recommendations based on this report, including some that relate to the findings of the study, and we just pushed the department to link to post-arrival migrant healthcare as much as was feasible. And they sort of acknowledged our recommendations, but we're not really clear on to what extent they accepted them and embedded them into practice. Yeah, I'll get onto the actual paper in a moment, but just by way of background, I think it's important to remember that Australia has, a pretty low burden of TB, but in terms of the concentration in migrant groups, it's particularly high in the case of Australia. We're now up to around 90%. And this is a figure from a paper on migrant TB in migrants that was published by Knut Lonroth and others a few years back that emphasizes just how concentrated our epidemic is within migrant groups, which I guess reflects the fact that we've had very successful control in Australian-born populations, and so that the denominator is not much greater than the total number in migrants. So I think it's particularly, when we're thinking about TB in Australia, of course, it's particularly important to think about TB in migrants to Australia. And looking back at other papers that have been done, there was a paper published in Lancet Infectious Diseases in 2016 that looked at what was referred to as a pilot program of migrants to the UK. It was smaller than the data set that we were able to look at. And another important distinction from this piece of work is that this was pre-arrival migrants, pre-entry screening only, whereas the data set that's available from the Department of Home Affairs looks at both onshore and offshore screening prior to visa being granted, but all IMEs that include a significant proportion, I think around a third, that are done onshore by Bupa Health Services from people who have already moved to Australia but are applying for their visa onshore and still meet screening criteria. So I think this is probably the most comparable study that was done prior to R1 being published, and they found a prevalence of bacteriologically confirmed TB of 92 per 100,000 population in offshore screening only. So to sort of, I guess, to jump straight to the main conclusion of our paper is that the rate of active TB in migrants to Australia was 53 over the study period. There's a 3-year study period that was from mid-2014 to mid-2017. And I think the other thing to emphasize is that it's actually sort of the unit of analysis is actually applications. It should map pretty closely to applicants because usually one applicant has one application. And for example, if you're diagnosed with TB during your application process, you'll still have that same application record number. But it is sort of a minor consideration that we were referring to them as applicants throughout the analysis, but it's probably slightly more accurate to refer to them as applications. So our result was a bit lower than the UK's, but acknowledging that the rates of TB in onshore applications are lower, and so that would dilute it out. And so sort of relatively comparable, I think, in terms of the results that we found, that it's somewhere around that, 50 per 100,000 applications received from offshore. If we break that up by country, I guess the best thing to look at is the little blue markers, which represent the prevalence with associated confidence intervals of active TB in migrant groups. You can compare that against WHO estimates, which are the green markers. And I think it's quite interesting to note that it's very, very similar for some countries, and places like the Philippines and Indonesia, it maps very closely, and a number of other countries as well. And then there's this sort of discrepancy that is largely notable, I guess, in the Indian subcontinent, in countries like India, Pakistan, and Nepal, where the rates of TB and applications for migration to Australia is significantly lower than what's reported in WHO estimates, which I think we probably can speculate about that a little bit as to what the reason for that might be, although we can't really gain any insight into that from the data set. I mean, I think the speculation is sort of word of mouth conversations about effectiveness of quality control in some of these countries that might potentially be lower in these countries. But we also clearly have to recognise that the cohort of migrants applying for visas to Australia is very different from the general population in those countries. So the other thing, I think that the other really interesting comparison to make was a comparison to a sort of a similar study that was done about 10 years ago and published in the MJA, which was at the time that Paul Douglas was working at the Department of Immigration and Citizenship, I think, back then. This was a bit of a different study. They hadn't moved to the electronic medical record system at this stage, so I think they were actually inferring both their numerator and their denominator, but still you can make some comparisons between our study and that earlier study to say that it seems like if you break things up by country, there's a general decline in quite a few countries in the proportion of applicants who are positive for active TB. So again, you could speculate about the reasons for that. I don't think that the data set that we have really enables us to be conclusive about that, but it's perhaps a little more striking than what we would think at a global level has been the decline in TB incidence overall, which is usually estimated at about 1.5% per annum decline. So I think results are potentially important, and I think it's also important to compare to what is perhaps the most recognised large study of migrants arriving in any setting prior to this, which was published. The British one that I showed earlier was published 5 years ago. This one was published, I think, about 12 years ago in 2009 and published in the New England Journal. And so is, I guess, partly because of the journal that it's in, it's recognised as one of the most important studies of migrant screening that is sort of often, I suppose, used by public health authorities to estimate the proportion of people who can be expected to have active TB. Some of their main results was that they found that the rate of smear-negative TB was 961 cases per 100,000. Again, whether that's applications or applicants is a little bit of a moot point, but probably per 100,000 applicants. And the rate of inactive TB in addition to that was another 837 cases per 100,000. So this is about one order of magnitude or 10-fold higher than even the British study found, and maybe 20-fold higher than what we found. But I think one of the reasons for these very dramatic differences between our findings and the findings from this American study are that the definitions of smear-negative TB and active TB were very, very different between the two studies. So in the case of smear-negative TB, it was a suggestive of active TB with 3 negative sputum smears. But suggestive of active TB, I think, probably wasn't very well defined. And as I mentioned, the definitions weren't particularly well defined in our data set either. So I suspect this is really quite a considerable overestimate of the true prevalence of active TB in applicants for migration to the US. And I guess as sort of, so in our study, or in the DHA data, I should probably say, the chest x-rays were reported with this categorical outcome variable, which included evidence of TB and strong suspicion of TB as two of the possible responses that could be used within that field. But what we used to define whether people actually had active TB was a diagnosis of TB, a diagnosis of active TB, which is something that the medical officer of the Commonwealth decides based on recommendations from the panel physician who is assessing that applicant. So we believe, and with our discussions with DHA, we're pretty sure that clinical diagnosis is much more in keeping with whether the person actually had active TB or not than just the results of the X-ray finding, the categorical result of the X-ray finding and the result of the sputum smear. So our results are a bit more consistent with the British results, and I think what we're probably seeing here is an overly broad and overly sensitive diagnosis in terms of estimating the rates of active TB in the migrants to the US. So I think that sort of suggests that our study does significantly advance over previous understanding, although we would still strongly advocate that we need to understand better what the chest X-ray field means in the case of DHA in order to really get a better understanding of the true rate of active TB in that cohort. I just wanted to quickly plug that we have just had accepted for publication a review of the cost effectiveness of screening programs for latent TB screening and treatment strategies in migrants to low incidence settings, particularly looking at Australia, and that will come out in the American Journal of Epidemiology soon. That was led by Katie Dale, and actually the conclusion might have changed, I think, in review following what I've put up here, but I think her quite firm opinion, I'm not sure whether she's in the audience, has been that screening is not going to be cost effective, even for latent TB infection. So I guess that's something else that we could discuss, but I'd better wind up. In fact, I can finish there. I guess I think I'm at time, so I can just...
Thank you, James. So we'll have to move on.